Welcome back to the step 3, which is the prosthodontic step. So the patient telephoned us to tell us that he had a little bit of sinus congestion 2 days after the sinus lift, which is common, and it was also springtime. So we advised the patient to use a little bit of Nasonex in each nostril, 2 puffs twice a day, and we followed it up after 3 days, and he reported that everything had settled down and that went smoothly. The patient then returned to us 5 months after the sinus lift, and we immediately took a radiographic control, and let's have a look at that image. So as soon as I took this x-ray, I was smiling already because I could see that everything looked perfect on radiograph, and we proceeded with restoring this case. So we anesthetized with ligna, span, buccal and palate lead the 1/6 and the 4/6 site, and we exposed the 1/6 and 4/6 implant, and we immediately performed an ISQ stability test, and I was delighted to see that the 1/6 site had readings of 86 from the buccal palatal, which I call the X reading, and he had readings of 86 along the A reading, which is mesiodistal. On the 4/6 site, the X reading had readings of 91 and the A reading was 92. So both implants were really stable, very high readings. I was delighted to see that. We had very strong readings, which indicates excellent osseointegration. We placed an impression coping in the 4/6 site and proceeded with an open tray impression using silicone. This is a picture of the open tray impressions using silicone material, but it is very important to emphasize that we always recommend taking peri-apical x-rays, no matter how sure you are that the impression copings have engaged the implant body. It is paramount that you always check that step. This was the impression of the lower implant. I also highly recommend always that once you've taken the impression, literally spend 10 seconds looking at your impression carefully, making sure that all the margins are where you need them to be and that there isn't any important information that your laboratory will need that hasn't been picked up in the impression. This is the best and easiest time to correct any inaccuracies. And finally, we placed a healing cap in the 4/6 site and placed a single suture. We repeated the same process on the upper. An impression coping was placed into position. Some light body silicone material was placed around the site. An open tray impression technique was used to take the impressions of the upper jaw. Once again, an impression of the upper jaw. You always need to check very carefully the margins of your implant and the margins of especially the adjacent teeth to make sure all the necessary information is there for the laboratory to be able to do their work. And finally, an upper healing cap was placed into position. I was delighted that the patient had already repaired his upper missing composite. One of the points which is especially important is when I place healing caps, I always make a point of making sure that I use the torque wrench and torque them at 20 Newton centimeters, which is the ideal torque for the ostium restorative platform. Different implant systems require different torques, and it is a very good idea to follow the manufacturer's guidelines because you won't lose healing caps like that. Once the crowns had been manufactured and the lab work had been sent to me, and I, as a standard protocol, want the lab work in my hands a week before the patient is going to be seen so that I have a chance to have a look at the lab work and evaluate it carefully. If there's any modifications, you can still make some adjustments and send the work back to the lab and back on time for the patient's fit appointment. Let's have a look at that. This is an occlusal view of the 4/6 implant crown in position, an occlusal view of the 1/6 implant crown in position with the lab screw. I had a very good look from the front to make sure that the crowns did not stick out. This is quite important, especially for patients that haven't had any teeth in the back of their mouth for quite some time. The buccal mucosa tends to fall into this area. It is important that these tissues do not encroach upon that area and that they remain within what we call the envelope, being the ideal occlusal arch. We check that very carefully. And one of the things that I also do in cases like this, because the tongue tends to always bulb out into this area, and this is specifically what I'm talking about, because the tongue has learnt to move into this area, to seal this area up as the patient chews, this tongue is going to reject teeth in this area initially. Patient is going to bite this tongue a number of times, and you have to coach your patient carefully with this. It is also very important, therefore, that when you place crowns in the top and in the bottom here, that these crowns are placed in such a way that they remain within the occlusal arch and not go too lingual or too buccal. And with that in mind, I always inspect these crowns from all the angles. So here's the side view of what the crowns look like. And I also want to make sure that it's easy for the patient to be able to clean these areas with an interdental brush. This is the working model on the other side. And because we knew that the patient had a less than ideal occlusion, and because we knew that the patient bruxed, from the outset it was a non-negotiable that he had to wear a bite splint, and he knew that. It was on his treatment plan and he had agreed to wear that. And I'll show you that in a minute. And finally, I also like to inspect the crowns from the posterior. In other words, the view that you can normally not see unless it's outside the mouth. So this is looking from the inside. And we can see the 4-6 and the 1-6 site. It is a good idea to remove the silicone that the lab place in these areas to replicate the gingiva, to make sure that the contact points and the emergence profiles are ideal. And finally, we designed an upper modified Michigan bite splint for the patient to wear. This is made from hard acrylic. There is buccal coverage of the 4, 5, and 6 area, but no buccal coverage of the upper anteriors from the 1-3 to the 2-3. This is a picture of the working model without the implant crown on it, the upper working model. This is a view of the lower working model without the crown on it. And finally, the upper working model with the crown and the modified Michigan bite splint in position prior to the fit appointment. At the fit appointment, both implant crowns with torque to 35 Newton centimeter. We check the contact, the occlusion with shim stock and articulating paper, and the aesthetics, and everything looked beautiful. This is a view of the 4-6 in position. Once we had torqued the screws into position, I tend to wait a few minutes and then re-torque them a second time. The access holes are then closed using Teflon plugs. We then use Clearfill S3 Bond and Filtex Supreme XTE Composite, which we cure and we polish and finish to a perfect finish. So this is a view of the upper jaw with the implant crown in position and the access hole closed, and a view of the lower jaw with the implant access hole closed. Finally, before I release the patient to go home, I check the occlusion in centric and excursions to make sure that the patient has a balanced and clean occlusion. And finally, we gave the patient a modified Michigan bite splint to wear at night because of his bruxism. And finally, the radiographic control of the final work, and everything seemed to be in order. And with that, the patient was delighted. He immediately reported to us that the process had exceeded his expectations, and that's always really good. But I was a little bit cautious, and I said to him, I want to see you in a few months again. He agreed to return to my surgery for a control appointment 3 months post-op.